Welcome to this explainer. We're diving incredibly deep into the imaging diagnosis of hydrocephalus today. No need to dust off your textbooks for this one. We are breaking down every single radiographic hallmark you need to know, point by point. Let's get straight into it. Here's a quick roadmap so we don't miss a beat. Section 1 covers general imaging info, then we'll calculate the Evans ratio in Section 2 and immediately tear down its limitations in Section 3. We'll wrap up with evaluating the temporal horns in Section 4 and other suggestive imaging findings in Section 5.
All right, Section 1, General Hydrocephalus Imaging Info. Let's establish our baseline tools.
So, mostly we're looking at CT or MRI scans, right? Those are your absolute gold standards for visualizing the brain. But, and this is a really neat detail, ultrasound is actually a super practical option if you're dealing with infants whose fontanellas haven't closed up yet.
Now, experienced clinicians can usually just spot ventriculomegaly visually. You look at the scan and you kind of just know. But here is a huge pitfall you absolutely have to watch out for. Normal ventricular size naturally increases as we get older. You literally can't apply a 20-year-old's baseline to an 80-year-old scan.
Because eyeballing it is so subjective, we do have quantitative linear criteria. But honestly, they aren't perfectly satisfactory. That's exactly why calculating total ventricular volume is being proposed as a much more accurate alternative for the future.
Okay, moving to Section 2, calculating the Evans ratio. You're going to hear this term all the time, so let's nail down exactly how it works.
Check out this beautifully rendered watercolor diagram. It really highlights the key landmarks perfectly without getting bogged down in noise. You've got your frontal horns, your occipital horns, and your temporal horns. These fluid-filled spaces are exactly what dictate our math.
Here is a wild piece of history for you. The Evans ratio wasn't even designed for modern scans. It was originally made for pneumoencephalograms, where they literally injected air into the ventricles, and only much later did we just kind of adapt it for axial CTs and MRIs. Crazy, right?
So how do we actually calculate it today? It's a strict three-step formula. First, you scroll until you find the slice with the absolute largest internal biparietal diameter, the BPD. Second, you measure the maximal width of the frontal horns on that exact same slice. And third, just divide the frontal horns by that BPD.
Once you've got your number, you check it against this scale. 0.2 to 0.25, you're totally normal. 0.25 to 0.3 is your borderline gray area. But if you hit anything strictly over 0.3, that formally indicates ventricular enlargement.
Sounds straightforward, right? Well, welcome to Section 3, Limitations of Evans ratio. We are about to completely tear down the math we just learned. First massive problem, your result isn't absolute. The ratio actually fluctuates depending on the exact angle of the axial slice. Just a slight tilt of the patient's head or the scanner itself can literally change your diagnostic number. There's no way around it.
Remember step 2 of that formula, where you force both lines onto the same slice? Well, anatomically speaking, the max internal width of the skull and the max width of the frontal horns often don't even align. It's like forcing a square peg into a round hole.
And for pediatrics, this is an absolutely crucial red flag. Relying on frontal horns can dangerously underestimate hydrocephalus in kids. Why? Because children often get this disproportionate dilation in their occipital horns instead. So the frontal horns look fine, but hydrocephalus is definitely still happening.
Ultimately, the inherent mathematical variability of this ratio, thanks to all those factors we just talked about, can honestly just overshadow the physical measurement of the frontal horns altogether. The mathematical noise basically drowns out the actual anatomy.
Because of those severe limitations, let's jump into Section 4, Evaluating the temporal horns. Many consider this a much more sensitive early indicator.
First things first, establish your baseline. Scroll to the highest cut passing through the petrous temporal bone. In a totally healthy brain, those temporal horns should be barely visible. Almost completely invisible, really.
So when is it a problem? Hydrocephalus is highly suggested if both temporal horns are 2 millimeters or wider, and your scan shows a total absence of the sylvian fissures, interhemispheric fissures, and cerebral sulci. Essentially, the brain is swelling so tight against the skull that it's just erasing those normal grooves.
Or we can use criteria 2. Both temporal horns are 2 millimeters or larger, but this time paired with a frontal horn to inner diameter ratio greater than 0.5. Now, hold up. Actually really pay attention here. Do not confuse this with the Evans ratio. The ID here is the inner table to inner table diameter, specifically at the level of the frontal horns, not the max BPD.
Almost done. Section 5, Other Suggestive Imaging Findings. We're going to rapid fire through 3 nonlinear clues you can spot visually. Finding number 1, significant ballooning of the frontal horns. When they expand outward dramatically, they create this highly recognizable shape, clinically nicknamed Mickey Mouse ventricles. If you see the mouse ears, suspect hydrocephalus for sure.
Next, look down at the third ventricle. Normally, it should be this very tight, slit-like space. If it loses that sharp shape and becomes noticeably widened, that's a massive red flag staring right back at you. Finally, check for periventricular signals. That's low density on a CT or high intensity on a T2 MRI. People used to call this transependymal flow, but actually, scratch that. It's a total misnomer. Fluid doesn't penetrate the lining. What you're actually seeing is fluid stasis, pooling in the brain tissue right next to the ventricles.
So, having broken down every detail and realizing how incredibly flawed our traditional linear measurements can be, it leaves us with one huge question. As our software gets smarter, how long until calculating total ventricular volume becomes the undisputed gold standard, leaving the Evans ratio entirely in the past?